Good afternoon, everyone. My name is Donney John. I am the Executive Director of Nova ScriptsCentral, a nonprofit pharmacy that provides life-saving medicines and education to the underserved here in Northern Virginia. I have the distinct pleasure of moderating an excellent panel with some very distinguished panelists. So I'm going to take a brief moment to introduce each of our panelists, and then we're going to jump into what I hope is going to be a very thought-provoking discussion. So first we have Ms. Quita Highsmith. She's the Chief Diversity Officer of Genentech. Then we have Dr. Erica Sutton, the Associate Dean for Academic Programs and Affiliation at Morehouse School of Medicine. Then we have Dr. Eleanor Walker, the Director of Breast Radiation Oncology and the Medical Director of the Henry Ford Health System Integrative Services. And then finally, we have Mrs. Regina Atkins, the Legal Associate General Counsel and Global Medication Delivery Global Technical Services at Baxter Healthcare Corporation. Say that 3 times. So today's discussion is a very important discussion, and we're really going to jump into some really heavy topics. So the first thing we want to highlight is that minorities were more susceptible to COVID-19 due to their underlying medical conditions. However, the pandemic caused many minorities to stop seeking routine medical care due to the country shutting down, hospital facilities shutting down, and the general lack of knowledge about COVID-19 virus at the time. So Dr. Walker, what have you witnessed as the current impact of people foregoing medical care during the COVID-19 pandemic?
Hello, everyone, and thank you for allowing me to participate in this distinguished panel. It has been very difficult this year seeing what has happened to our people. Unfortunately, many of the underserved and minorities in this country use the emergency room and urgent care centers as their primary medical care as opposed to having a PCP. And even those that have a primary care physician don't necessarily go regularly for screening. So when COVID hit, even if people had things going on, they did not go to the ER because they were afraid of picking up COVID, especially in hospitals like the Henry Ford Health System here in Detroit, Michigan, where we have a lot of underserved patients. We're in the middle of an inner city, so people were very, very afraid. And then normal screening exams, for example, like a mammogram, getting colorectal screening, lung cancer screening, some of the basic screenings that are done, they did not come. Even after hospitals reopened and started doing more screening, they did not come. Hence, in the oncology field today, we definitely are seeing a lot of later diagnosis, especially in minority and underserved patients. And that goes across the board in cardiac disease. A lot of people did not come in, a lot of people dying at home. So it's been very sad.
I have to unmute myself. Dr. Sutton, what have you noticed as the trends at Morehouse School of Medicine in regards to the delay of care?
Exactly as you heard from Dr. Walker, that people were fearful to interact in a healthcare setting. And so there are definitely delays to cancer screening, and there were delays to routine care. But then as either chronic conditions became emergent conditions, we saw an influx of an effort to seek care in either emergency rooms and primarily emergency rooms. And the initial presentation of some chronic conditions being more severe for having had a year of not seeking care.
So Ms. Atkins, from an industry standpoint, how did the delay in care impact Baxter? Because there was a high demand for resources that, we were running short of supplies, but from your perspective, what was it that you witnessed?
Yeah, thank you for that, Donney, and thank you for inviting me. In fact, Tuesday is our earnings call, so I have to be very in what I talk about. But with that said, at a very, very high level, obviously, I support our medication delivery business, and that portfolio consists of our IV solutions, our IV pumps, all of which are used in critical care settings. And what we saw is, on the one hand, there was a sort of an increased demand, if you will, for our renal, dialysis patients that were hit pretty hard during COVID. But on the other hand, we saw a drop because, as Dr. Walker mentioned, hospitalizations, particularly elective surgeries, went down. And so consequently, we saw a little bit of, across the board, if you look at not only Baxter, but if you look at other healthcare companies, particularly those that supply some of those critical and basic and essential drugs, we took a bit of a decline.
Ms. Highsmith, from Genentech standpoint, being at the leading edge of research and cutting edge discovery, what was it that you witnessed?
I think what COVID did really was to elevate the inequity that we all know exists. All the people on this call know inequity in healthcare exists. And it is an urgent issue for Black, Latinx, and other historically marginalized communities. One of the things that we did to better understand what can we do now is we did a study in over 2,000 patients in the fall of last year to really help us understand what is the experience of Black, Latinx, LGBTQ, and low socioeconomic income status, meaning people who made $35,000 or less. And let me tell you, these people are very disenfranchised. They don't believe that the healthcare system has their benefit. They have very low trust. They don't want to get vaccinated. They told us that. They actually said that they believe that their doctor might not even give them the best treatment for them, and they're not confident in a healthcare system because of the interactions that they've had, that the healthcare system has not been considerate, has not been empathetic, and does not fit their needs. But the thing that we have to do is we cannot blame people, the patients of color, because they've had some real issues and concerns with the healthcare system. We need to be thinking about what are those solutions that we can bring to the table.
Excellent points. Before I forget to mention, if the audience has questions for our distinguished panelists, please put them in the Q&A box and I'll make sure I try to get through as many of them as possible. So one of the things that we witnessed is the huge toll that's taken on our healthcare workers. Healthcare workers across the country face tremendous stress due to the COVID-19 pandemic. Many losing family members, colleagues, loved ones, all still while tackling the needs of their community. How are organizations and companies addressing the mental health issue, the health burden that healthcare workers are facing? So Dr. Sutton, would you like to take that first?
Sure. So there's no more room for lip service around mental health.
Mm-hmm.
There's no more room for EAP programs on the books that aren't providing meaningful resource and support to employees and their families, to understanding the accommodations that are required of not only healthcare workers, but all employees, and maybe perhaps particularly those in healthcare related industries, to take care of their families, to take care of themselves. And so there has to have been some real recognition of the healthcare worker as human, and that the old adage of "doctor, heal thyself," it's not appropriate, and it's not effective. And so to see that trend in healthcare, acknowledging that mental health awareness and mental health action is necessary, has been refreshing. Now, what has taken place, or what can we look at to say has in fact really occurred? I think that leave policies work, remote work policies are in place, but there's still a lot to be done to effect meaningful improvement in the quality of health care that is received by people who have been affected on the front lines.
Dr. Walker, you were in the hotspot of COVID at some point last year. So can you give us your perspective on how Henry Ford, is trying to really encourage or address the mental health issue? Dr. Walker, you're on mute.
I'm sorry. We're still in the hot spot. We're in our third wave right now. The numbers are getting a little better, but I agree with Dr. Sutton totally. Henry Ford Health System has, EPA, employee assistance programs. They've started a weekly noon virtual seminar for employees to get on if they wish to. They've developed a buddy program, and they're lots of resources available, but again, it's difficult as a physician, as a healthcare worker, the nurses, everyone to really always take advantage of it. We don't really have the option of working from at home. I know some healthcare systems, some of their physicians did work from at home, but I personally didn't feel like I was giving my patients my all. I'm going to be there with them. But I think, as Dr. Sutton said, the system is trying to balance taking care of us and giving us the mental health time we need. There is not a meeting that I attend with our administrators, our own departmental chairs and staff meetings where this is not brought up, and try to create a safe space for people to talk about what's bothering them as healthcare givers to these patients. And then also the fear of exposing your family. You know, it's not a simple thing. As I mentioned in the past, I personally lost 17 friends in 1 year of COVID. Okay, we're on our first year anniversaries now. That's taken an emotional toll on me. There's no question. And then the fatigue of still doing the same thing. We want people to realize we are people too, and we need them to help us get out of this pandemic.
Excellent points. Ms. Highsmith, from Genentech standpoint, how are they addressing the mental health crises?
You know, I think now more than ever, our personal and professional lives are blurred, right? Because we're in the house. Like, I didn't invite y'all in my house, but you in my house right now. So one of the things that we are doing is, you know, like these virtual backgrounds, because sometimes you might not be in a place where, you know, your house looks perfect. And, you know, we don't want people to have that unnecessary burden and stress of perfection, because we didn't plan to be working from home all this time. On top of that, you know, all the racial unrest, employees are expecting us to really speak up. And one of the things that we started last year at Genentech is we started having what we call dialogue circles. And we're going to have 2 this week, post this George Floyd verdict. And it's really the first time people have been able to have discussions at work about race. And it's a conversation that is needed to be had, because there are some who don't understand the everyday burdens of being a Black person. I got a fancy house, fancy degrees, fancy car, but I walk out my front door, I'm still a Black woman, and they're not asking me about my degrees and where I went to school. They just see the color of my skin. And this is our opportunity to really address it so that we can wake up some of our colleagues. And we've had outstanding response. We did almost 20 of these last year with more than 250 employees attending. And I think it makes a real difference when you stop tiptoeing around race at work, but really start to address it. Then you can mentally be free.
Very good points. Ms. Atkins, what about at Baxter? How are they working on this?
You know, I would say overall, Baxter's response has been fantastic. Again, from a personal standpoint. And I think for a number of reasons. I think, you know, if you sort of look at the small gestures, you know, from just your direct managers or senior executives stressing the importance, particularly during the pandemic and working from home, stressing the importance of taking time off, encouraging employees to take time off. So again, when I say the small thing, so it's not unusual for me to have a conference call on an afternoon walk, during an afternoon walk. That's been fantastic for my mental health. But on a more formal basis, Baxter, you may have heard, Baxter launched a global initiative called Activating Change Today. And that is our response to address racial justice. And so we have a number of focus areas, including the workforce and our workplace, looking at ways to have you know, those dialogues about race, about racism, about injustice, about health inequities, So again, from my perspective, I am a member of that team, of that ACT Global team. I focus primarily on our marketplace, meaning, how to close the gap on health disparities. But I think, in short, cultivating an environment, particularly in these times, of having open and honest dialogue among employees, I think is fantastic for overall morale for the corporation.
Thank you, Ms. Atkins. So one group that's been tremendously impacted, but that's not often focus hours, there are students. Whether there are students at pharmacy school, nursing school, medical school, they've been directly impacted where there's been a lack of rotation sites. Schools are shutting down, so they have to do virtual learning. So Dr. Sutton, how did Morehouse School of Medicine navigate and really help students thrive during this global pandemic?
The first thing that we had to do was to show an extreme amount of adaptability. Things that had been assumed to be true for, I would say, easily 100 years of medical education, we learned weren't necessarily true. And the model of a sage on the stage that's presenting all of the information in the lectures, it had to go away. And we had to pivot to virtual instruction. We had to look at flexible timelines for achieving objectives. We had to be honest with ourselves about when are we saying somebody is a doctor because 4 years have passed and they overall passed a class, versus what is it that we can say they actually know how to, what they know and what they can do. And so that resulted in kind of a shift to competency-based education and advancement criteria. So so that has been very impactful as we continue to look at what are those things that are going to return to medical education in the way that we knew them, and then what are those things that we were wrong about as enduring aspects or components of medical education. And in fact, have we found a better way out of this to educate to learners and healthcare professionals?
Thank you. I want to note there are calls on the Biden administration to really set up a national tracking system of COVID-19 deaths amongst frontline health workers to honor the thousands of nurses, doctors, and support staff who have passed. There's no national database that has a concrete number that's tracking the number of lives that we've lost. One of the resources that I'm putting in the chat, there is a project that was jointly done by the Guardian and Kaiser Health News called Lost on the Frontline. And they created a tracking system to track all the deaths and share the stories of the hard healthcare heroes that unfortunately lost their lives during this pandemic. So it's really important that we create this national system to track these outcomes. And Dr. Cameron Webb, in the morning opening session, he had a brilliant statement where he said, if you're not tracking it, you can't treat it. So I really hope that the Biden administration really takes the important steps to create a national tracking system so we can really figure out how do we get to the root cause. How do we address these things? Because as you've all alluded to, we can keep tiptoeing around the situation, nothing changes, or we can really go ahead and be more action focused, which is what we need to be. Outside of now, we've talked about the impact on patients, on the healthcare team, but now let's talk about the economic impact, because that is a huge burden that the healthcare system underwent with 3 rounds of the PPP loans to help support the economy. But how did that really help the healthcare industry? So Dr. Sutton, I'm going to lead it off with you. Could you give us some, from your perspective, how did the PPP loans or the financial impact of COVID impact the healthcare, the medical system?
I'm gonna poke the bear a little bit on this one, because the healthcare system's fine, and the healthcare system will financially be okay. It is the individuals, and particularly I would say providers, healthcare workers of color, who suffer disproportionately. I would like to say, the title of this panel is "Racism Makes Me Sick," and I'm thinking it's important to track the healthcare workers, but in doing that, we are going to be tracking disproportionate numbers of affluent, highly educated non-minorities. I just want to be honest about that. It's important to track, yes, but in reference to mistrust that was referenced earlier, the we can no longer gloss over these really difficult conversations and cultural problems that came about. And so I want to say that mistrust is because we sent out a message that said, stay in your house, be safe, protect yourself. This is a dangerous disease, except for you, and you, because you're essential workers. And that happened to hit a spectrum that involved healthcare providers and healthcare, but also people of color who make up the essential workers, Black, Brown, Latinx. And so I want to point out that yes, there's going to be financial impact to healthcare, but in general, there's so many different things that are involved in healthcare. Just recognize what end of that bell curve you're talking about financially, in terms of its financial impact. I'm most worried about my rural physicians who are, serving communities where there's not another doc for 4 counties. Those are the people that I would hope we are paying more attention to and looking at the financial impact and stimulus to their service.
Thank you, Dr. Sutton. Dr. Walker, can you add some thoughts?
I have to agree with Dr. Sutton. When I think about the PPPs that were put out now 3 times, a lot of people of color and essential healthcare workers and Black businesses weren't able to get them. Mm-hmm. In fact, in talking to someone I know who's an accountant, even he was saying it's amazing how these big companies that they do their paperwork and their taxes every year, they were able to get how many thousands of dollars in PPE, and they're using it to invest in this or doing that. They weren't really the people that needed to get it. And I don't think, as Dr. Sutton said, the big healthcare systems, they'll make it. I mean, their bottom line may be down a little bit for the next year or 2, but they're going to come back, and they're going to come back well. But the people who were working, who had to take care of kids, had to take care of their elderly parents, their sister, whoever, they didn't get that PPP. And so what has happened to them and what is going to happen to them? That's the question.
One group that was directly impacted, we know about medical practices, but really I want to talk about dentists, optometrists, and other allied healthcare professionals that have practices that had to be completely shut down because of the government mandates of limiting access to services during this crisis. Those are different healthcare professionals that were not initially eligible or were easily able to get the PPP loans in the first round or the second loans, but they're still struggling to kind of get back to their volume of where they were before pre-pandemic. Now, the pandemic, it's definitely impacted the health system, but it's also impacted industry in terms of a lot of different aspects of it. So Ms. Highsmith, could you kind of highlight from your Genentech role, what did you witness in terms of the financial impact that COVID had on our system?
I'm going to follow Dr. Sutton, and let's poke the bear. Let's talk about the financial impact on patients of color, whether they have healthcare coverage and the affordability of that. Because if you got great healthcare coverage, you don't have to go to the emergency room to get your healthcare. But historically marginalized people who don't have same access, who have high co-pays, who don't have access to the proper foods, who live in red line neighborhoods without medical care, or a pharmacy, maybe don't have good transportation or good jobs that give them paid time off of work to go take care of their illnesses, the financial burden for them is high. And what we need is more equitable access. Right now, there are only 16 states, Medicaid, that actually offer routine care for patients participating in clinical research. We need to widen the access of who gets access to clinical trials, who gets asked. Not everybody who's eligible, especially if you're a person of color, gets asked. One of the things that we're doing at Genentech, and we just launched our 2025 commitments, is we're asking all of our teams to ensure that they have advanced and inclusive research plans. We actually did a study our Impacta study, which is looking at COVID-19 pneumonia with almost 400 patients, and 85% of the patients in that study were from communities of color. And people were like, well, how did you do that? It's not that hard. Let me tell you what we did. We went to where the patients are. We went to community hospitals. If you're driving by the hospital every day, that's the hospital you want to go to, right? We want to go to the Howards. We want to go to Oakland. We want to go to where patients of color are, the Navajo Nation, right? And a lot of times in this industry, it's like, well, if you go to this, that, and the third of a hospital versus the, big ivory tower academic center, you're not going to fill your study up. That's not true. That's a fake news. What's actually true is if you go to where the patients are, you can find patients. And so what we need to be thinking about is, how do we address the financial burden that patients of color have so that they can participate in the healthcare system?
No, excellent points. And one thing I want to highlight, based on an earlier panel discussion where we were talking about the impact of federally qualified health centers, and we talked about the NMQF's work with federally qualified health centers, FQHCs are a great source of patient care. There are tons of diversity, a lot of patients that go there because of trust. Aside from federally qualified health centers, there are thousands of health safety net free clinics across the country that provide high quality care to the uninsured. My organization provides care to over 2,000 uninsured patients in Northern Virginia alone, and we work with about 16 free clinics. So I do want to make sure free clinics are one of the best places to get that diversity as well, and also where patients go because there's trust built in.
Let me just add on. One of the things is we got to put our money where our mouth is. And so for us, we have about 46 million in grant dollars that we have provided to the community. And Dr. Walker at the Henry Ford Health System is one of the recipients, because they came to us with a project embedded about community-based participatory research, because the industry can't do it alone. We're not trusted in the community, and we have to partner with institutions like Henry Ford and physicians like Dr. Walker, who are like, I've got some ideas, but I need some funding. Where y'all at? Help us out.
And that's where, just to bring up, also, there's not enough of us as minority physicians. I'm sure Dr. Sutton, you're at Morehouse, so there's a lot of you, but if you look across the country, there's not enough of us. And my specialty is one of the worst. It's one of the 5 worst in terms of how many African Americans and women who are in my specialty, and how many Black and other minority patients get cancer. It's the number 2 killer in this country until COVID, of course, behind heart disease. So why aren't there more people that look like me in the field? Because people feel more comfortable with people who look like them, the thought that they understand what they may be going through. But at the same time, if you know how to communicate well with people and you're open, and as my mom always said, is talk to me in a way that I can understand. When I hit med school and I started bringing home those 10,000 words that nobody else knew, but that we learned, that's the first thing she told me. And that has always stuck with me. And I try to talk to my patients. I do participate in a lot of clinical trials. I'm one of the principal investigators for the NRG Oncology for the Henry Ford Health System. And I sit down and talk with patients that way, because if they don't understand it and they don't feel comfortable asking you questions, then even if you present it to them or go out in the community and talk about things that are available to them, they're not going to participate.
John, there's a great question in the chat.
So
And
the chat or the Q&A?
So I'm sorry, the Q&A. I'm sorry, the Q&A. You're looking at the Q&A.
So on one of the questions from the audience was, if the panelists could speak to the political upheaval that's happened. All of last year we saw with George Floyd and countless cases, and now we have basically a shooting happening every day. It's very sad. How's that taking an emotional toll on minority healthcare workers?
I want to talk about whether you're a healthcare worker or not, there is an emotional toll. There is a tax paid for both of those things. Young and old across the spectrum. And it's not that it's newly happening, it's that video is resurfacing that is 4 years old, 3 years old, 6 years old. It was always happening. And so you got to get up every day and do your Zooms, get your kids to school. But you also have to learn to talk to colleagues, talk to your children about that, about living Black in America or living brown in America, which just as Ms. Highsmith said, you know, on the Zooms, in this setting, on this panel, you're expert, you're regarded for your authority. And you walk out of your home, or your child walks out of their safe environment. And instead of being regarded for all the vulnerabilities that a 13-year-old has, they are regarded as a threat. And so we have to start having the conversations about hurt, pain, mistrust, the impact of that in the present and over time. You know, the lesson this week in my household was, do not minimize your pain for the comfort of others. That is a cultural lesson for this moment, but that's also a health lesson, because there is stress to be had there. There is additional burden and vitality that is taken from you to lessen your pain for the comfort of other people. That pain on the table is something that we have to deal with as a country now. And it's hard for everybody, but it's work we have to be committed to in our healthcare space, in our church space, in our hanging out with kids on the beach, family, all that space. It's time for this country to deal with it.
You know, Dr. Walker had alluded to something a little bit earlier, talking about the need for more diversity in the workforce. You know, COVID definitely shined the spotlight, saying that there's not enough diversity within our healthcare work environment to build trust, which is needed amongst our minority communities. Dr. Dan Lai, from an assistant professor of medicine at the University of California, just published a study in the Journal of General Internal Medicine, where it titled "Percentage of Doctors Who Are Black Barely Changed in 120 Years." That's pretty astonishing that that type of research is kind of providing these same results over and over again. You know, Dr. Norma Pohl Hunter, the senior of workforce diversity at the Association of American Medical Colleges, says studies have shown that diversity in classrooms creates a more enriched learning environment and increases civic mindedness and cognitive complexity. So my question to the panelists is, you know, and I'll start with Ms. Atkins, what are organizations like yours doing to really help address this issue of workforce diversity and the need to build more trust amongst minority communities?
Yeah, it's an interesting problem, particularly for a healthcare company to address. I think one of the things that we did at Baxter, I mentioned ACT, and so when I looked at it, I initially thought, when asked to join ACT, what can I as a lawyer do to contribute to this issue, right? And so I thought about, okay, so what's the connection? Well, COVID, you're right. COVID shined a light on disparities of health, whether that's, and we've talked about it, whether that's access, whether that's the quality of care, whether that's health literacy, trust, but all of those are directly linked to outcomes, and in fact, suboptimal outcomes. And so clearly there's data, as you probably know, that there's data and research suggests that a lack of diversity in healthcare has something to do with that. And as Dr. Walker mentioned, I think one large component of that is outcomes are better when you are being treated. I think the conversation is better when, or potentially better when, patients are being treated by doctors and physicians that look like them. And I can, I'll give you a personal experience myself. When I sort of look at my parents and my grandparents, when they visit the doctor and I ask, how did it go? the question is always fine. Like everything, and I say everything can't be fine, right? And I think that's a difference versus when I go to the doctor, I probably have 20 or so questions. And I think that is because, again, there's a lack of trust. And I think the conversation, and I think Dr. Walker hit it, is exactly right. I cannot stress the importance of physicians and doctors speaking with and speaking at a level that is culturally sensitive to their patients. And so what Baxter, we saw this and we're seeing this. And so what we, as a first step, what we decided to do is partner with medical schools, one of which is Morehouse, but really sort of partner with them to address this issue of increasing the number of diverse healthcare workers, right? And that's something that any organization can do. And it really is sort of funding. And I know that it's not the right term, Dr. Walker, pipeline programs. I know that they are
pathway.
I know they are
Pathways now.
Pathway programs. They are called something new today. But I think that's something, and that's contributing from a monetary standpoint. But I think it's certainly meaningful and certainly helpful. I think the other thing that corporations can do is to partner with, again, medical schools and sort of identify opportunities that would assist in any way their students. So whether that's financial, whether that's providing mentoring opportunities, whether that's providing research opportunities that may ultimately help them get to where they need to be. So these are things, I think from a corporate standpoint, you can look at. And I think thirdly, we tend to be focused on, products and services. And we looked at, okay, how can we help our customers, doctors, right? The workforce. And that is maybe educating them if they're not already, but helping to address unconscious bias, which is a tremendous issue. So those are just a few examples, I think, what companies can do to address this issue.
Ms. Highsmith, can you speak to some of the initiatives that Genentech is undertaking?
Yeah. First of all, we can't be out here talking about diversity and inclusion when our own house ain't together. So real change starts at home. So one of the things that we have just done at the end of Q1 was we released our 2025 commitments. And in that, we are going to double Black and Hispanic representation and the leadership. We have a high portion of Asian Americans in our employee workforce, but they're not in leadership neither. We're asking all of our research teams to include inclusive research plans. We are planning to spend $1 billion with diverse suppliers, but we're asking all suppliers, not just the diverse suppliers. We're asking all suppliers, how diverse is the people that don't work on the Genentech business? What are your diversity and inclusion goals? Because we got to be thinking about the long term and the big picture and the influence that we have. And then we have a program called Kindergarten to Careers, where we're looking at how do we own the pathway, how do we do reinforcement on the pathway? Because we know funding is tough. Like we ain't came from 3-4 generations of physicians and PhDs and postdocs. That's a lot of money that people got to spend. My daughter's graduated from Howard on next Saturday, and she's going to genetic school. So at VCU, that's going to be a lot of money. Now she got a little scholarship, but guess who got paid the rest? Unless she takes out some loans, right? And so we don't all have the means to be able to go get the next step, no matter how smart we are in our career, because we've been behind. The other thing that we have to do, and Genentech is leaning into this, is we have to raise awareness with these medical schools, these graduate science programs, because I'm gonna give you a sad example. Because we've been working on advancing inclusive research and health equity for a number of years. But if we think about just even disparities and how our kids are treated, there was a JAMA article where they were looking at pain management in the emergency room for children 21 and under for appendicitis. And you know what? The Black kids didn't even get no pain medicine. They let little 7, 8, 9-year-olds suffer. But the white kids, they was able to get pain medicine. They don't even treat us the same. And we got to teach that. We got to start to ask more questions. And we also, we're looking to try to think differently about how we bring in early in career opportunities. We just launched a fellowship with Howard, the FDA, and Genentech, so that we can be specific about giving people the experiences that they need to come into our industry and then move up in their careers. So there's a lot of stuff industry can do.
Yeah.
I totally agree. I have to say, I applaud both Baxter and Genentech for doing what they're doing, especially going back. That pathway starts in elementary school, because we know by third or fourth grade, especially young Black males, if they don't reach a certain educational level and have mentors to show them the way, that's what pathway is. My area is very specialized. And so there's a lot of research. There are a lot of hoops you need to jump through to become a radiation oncologist. But if no one who looks like you is around or can help tell you what you need to do, if this is what you think you really want to do, then it's not going to work, which is why personally, as a physician, I work with my undergraduate, Notre Dame, to develop programs as a pathway. And in Detroit, the Black physicians here, our Opal group, we try to work with the STEM programs going all the way back into junior high school and high school to show them the way, help them become accomplished, make them eligible for scholarships that they should have. Because if you can't get into school, it doesn't matter how smart you are, you're not going to become the physician or the researcher or the CEO of anybody's company.
Let's talk a moment about the reason for the word pathway over pipeline, because pipeline made it sound like it was just one route and everybody had to be in that same route, that same line to get to a place. And the term pathway is now preferred because there's more than one route, and there's more than one way to achieve goals, to achieve inclusion and representation, but also to achieve all of the amazing benefits of a diversified workforce. So that's the reason for the term pathway. What in our work on pathway programs at Morehouse School of Medicine, we have found the need to reach back to kindergarten, because there are also so many opportunities for Brown children, students, to get on a divergent path, and not nearly as many people or opportunities that recognize that as being unusual or undesirable, or helping them to stay on a pathway that is academic challenge, that is achievement. To believe that a Black child who's performing at a C level is doing pretty good, somebody's got to get C's, is to not recognize the potential of the individual child, but to fall subject to a stereotype bias and a bias of low expectation. And I find that has been critical in our pathway work to fight these early biases about what Brown children can do and should become.
Thank you for that, Dr. Sutton. So, moving on to one of our big topic points where there's been a lot of Q&A about, the development of the COVID-19 vaccine may go down in history as one of the greatest medical interventions in a long time. And the only way that was possible was through multi-sector collaboration. So what can we do to build off of these collaborations? How do patient organizations and other non-traditional partners get involved, get engaged with a Genentech or a Baxter? For example, I run a nonprofit that's focusing specifically working on uninsured individuals to provide access to life-saving medicine. So how does an organization like mine that serves uninsured get more involved directly? Because maybe I don't have the right level of connectivity, that some people may have. But where do non-traditional partners, what do they have to do to really kind of be part of this multi-sector collaboration going forward? So why don't we go with Ms. Highsmith first?
Yeah, first of all, we looking for partnerships because we don't have all the answers. If we had all the answers, we'd be doing better, right? So we're looking for partnerships. One of them is we have an external council, which is built of leading experts in academia and patient advocacy, who are really helping us think differently about clinical work. I mean, like they went through our inclusion exclusion protocols of studies, and they was like, y'all basically looking for a white male from 20 years ago. You need to get rid of some of this stuff, right? And so like we're looking for partnerships, and every year, twice a year on our website, and we're asking for people, just like we had Dr. Walker proposal come forward. We're looking for the proposals that are going to make change. We are not interested in the fun run. That's not going to help us solve some problems. We're looking for organizations that want to come forward, that have some new ideas to help us think differently, because we got to tackle this problem, and we can't do it the same old way we've been doing it. That's not going to work. So call me.
I think that's, I think she's right. I think if you look at companies, for instance, like Baxter, we too, I think what COVID-19 has really done for corporations is a realization that we have to do things differently. We have to think creatively. We have to form partnerships where we may not have formed them in the past. I think it's a realization that we can't do it alone. We have to rely on organizations, healthcare institutions, to help us solve this problem. And for us, whether that's greater access to our products and services, one of the things, again, that we've launched, and we're looking at a myriad of collaborations and partnerships. But two things I wanted to stress. It is the importance of funding or evaluating, assessing, and funding community-based research. And perhaps that may not have been our primary focus, and it hasn't been, but I think it's one of the areas that we have to look at, because it's not enough to, everybody can talk about the disparities and what exists. But the question is, who is, and what doctors, what institutions are really developing community-based interventions to address those disparities and those obstacles. So I think that's another avenue for perhaps corporations can do, in addition to forming these kinds of partnerships that help companies go direct to the community. Again, so that's the second point that I want to stress. I think it's the realization that it's not so much the message, right, is important, but really who delivers that message and the manner in which it's delivered is critically important as well. And for us, we can't do it ourselves. And so, like Ms. Highsmith suggested, we are looking for these kinds of collaborations and partnerships. We welcome them.
So can we just send our applications both to your email?
John, I have a
on the website. We have a whole section on the website about how to submit ideas. So gene.com, everybody.
Yeah,
right, so we'll submit on
John,
the
I have a nonprofit too, and I have a nonprofit too, and that question is excellent, because it becomes a full-time job to look for those opportunities as well. But the need is great.
And I just want to say one thing. Part of the issue, I think it's so important to talk to the community about how they want to be approached, how they would like to see things. I think the NIH and the DoD found out a long time ago, because I've had the opportunity to be on their grant reviews for a few things. And it was the lay person who was part of the team who really helped us focus on some of these grants we were reviewing. And it's the same thing right now. How are we going to help our community, the patients, the students, if we don't get their input? But Genentech and Baxter have been wonderful about helping minority physicians. You know, the NIH, it's like, oh, if you haven't already, you know, published or gotten this grant for this, this, and that, they don't even look at you as a person of color. And Genentech and Baxter are really trying to help those of us who are trying to help our community and do the research that needs to be done with the community's help, of course, to improve our outcomes. So I think I just want to say thank you for that.
I think Dr. Walker, you highlighted a very important point. You know, a lot of the research funding that's coming out, there are many layers in order to apply, where if you don't have, like you said, a certain pedigree, you can't even say hello. You can't even start the conversation. You know, the most recent funding that went towards health literacy about the COVID-19 vaccine, if you looked at the request for proposals, it is pretty complicated, where small organizations like mine and other nonprofits that are truly boots on the ground working with the community were not eligible to really focus, you know, for the services that we're already providing. You know, so it's really important that, you know, as part of funding being available, there's a lot more transparency about how new fresh faces, fresh ideas can be part of that discussion of being awarded those grants, so they can actually be able to implement new ideas that are not stagnant in some nature. You know, and one of the other things that's really the need for the diversity in faculty in schools across the country. So it's not just in medical school, but when we look at nursing school and pharmacy school, the diversity of faculty is extremely important in all other healthcare disciplines. A lot of times we focus a lot of energy on medical school, but we have to look at what are the other professions that are really where a lot of our minority community members joining. They are really joining these other allied health professions that are extremely important. And unfortunately, nurses, according, you know, to the COVID crises, they were probably the most impacted by, you know, the pandemic in terms of, you know, work burnout because of the severe trauma that they were experiencing. You know, there is a Washington Post and Kaiser Family News, they did a poll and they found out that 6 in 10 healthcare workers, actually roughly 3 in 10 healthcare workers have weighed leaving their profession, and more than half are burned, and about 6 in 10 say stress from the pandemic has harmed their mental health. This isn't an issue that's going to go away. This is an ongoing trauma that we are going to, you know, as Dr. Walker alluded to, she's facing the third wave of COVID at her health system. So, you know, we are facing some uphill battles coming up. You know, there was a doctor by the name Dr. Lorna Brennan. She was an ER doc from New York, and she passed away from, unfortunately, via suicide at the early onset of COVID-19. And her family started a foundation, and they recently advocating for a new bill to be passed that really is going to focus on addressing, you know, strategies to improve mental health and behavioral health to prevent the burnout amongst healthcare professionals. You know, Dr. Walker and Dr. Sutton also alluded to how the lack of time for healthcare workers. You know, when you are struggling to serve your patients, serve your family, you know, the statement was made earlier, resources for employees and families. I think that's extremely important. You know, a lot of healthcare workers, you know, friends of mine were renting hotels, sleeping in garages because they didn't want to expose their loved ones to this illness. So there was this unaccounted burden that healthcare workers from all different sectors have faced. And one of the biggest burdens on top of that, student loan debt. Medical professionals are one of the highest categories of users that have medical, you know, student loan debt. But when you look at all the loan forgiveness and the things that are being discussed, there is no discussion based on forgiving loans for, you know, healthcare workers. There was a change.org petition that got, I think, over 100,000 participants, you know, signing it, that were advocating for healthcare workers to have their student loans forgiven, which, you know, if we want to talk about action steps, that would be one step to really focus on helping to reduce the financial and economic instability that as healthcare workers we face.
And I'm gonna keep it real with everybody on this call. I think that loan forgiveness should be given to pediatricians. It should be given to primary care doctors. It should be given to people who are doing good things with nonprofits that provide free jugs to patients that don't have insurance. I really believe that. I'm in a surgical specialty, and that affords, you know, that on average, you see those salaries are higher. And so I think that there can be alignment with contribution in that way, but I just can never lose sight of the fact that and maybe it's the way I was raised, but to those whom much is given, much is also expected. And I think that some of the things that we're talking about here, and social workers, somebody in the chat says social workers, those things disproportionately affect healthcare workers, really public health workers, mental health workers, across a certain income bracket. Now, it's a higher bracket than you might think in this country. It is a higher bracket than it's higher than 35,000. I'm to say that for sure. But the average salary for pediatricians, for family doctors, primary care deliverers, it might be 85,000 to 110,000. And student loan debt exceeding $250,000, $300,000. Average student loan debt in this country approaches $300,000 for medical school alone. That is significant when you are also raising a family, building a practice, taking care, of other human lives. So I can't help but always think there is even disparity in that.
Thank you, Dr. Sutton. So we're almost at time, and I just want to thank all the panelists for this wonderful discussion. And I just want to leave the audience with this one quote that Dr. Norma Powell Hunter had put in an article. And she said it best when she stated that diversity goal is not about quotas, it's about excellence. She said, when we know that there's talent that exists, we want to make sure that everyone has an opportunity to be successful. I think that's just the most beautiful way to say it, where we need to make sure that we provide the opportunity and we give everybody the opportunity to live long and prosper and wear a mask. Simple request. So thank you, panelists. I'm going to pass it back off to Brandon at NMQF. Hope you guys enjoy the rest of the programming.
Thank you.
Thank you.